Good evening, everyone. Welcome to COVID-19 update for primary care providers in the ACT. My name is Dr. Vanessa Johnston. I'm a public health physician with the Office of the Chief Health Officer for ACT Health, and I will be providing the presentation this evening. I do have in the wings two other presenters that will be available to answer your questions. One of those is Miss Wynn. She is our Infection Control Manager for ACT Health, and she'll answer all your infection control questions. And the other is Dr. Anne-Marie Svoboda, who is our GP Liaison Officer for Canberra Health Services. And I'm really thankful and happy that they're here today. I'd like to acknowledge the Capital Health Network for facilitating this webinar and for ACT Health and Canberra Health Services in providing the material and the speakers for this evening. Before we begin, I'd like to acknowledge the traditional owners on the lands in which we meet this evening, the Ngunnawal people, and pay my respects to their elders, past, present and emerging. And I'd like to welcome in particular any Aboriginal and Torres Strait Islander participants in the webinar this evening. So we'll get the presentation underway. Okay, great. Okay, so just a little bit of context. I'm sure a lot of you are across this detail, but for those of you that are not, the COVID-19 outbreak started in Wuhan City in the Hubei province of China in December 2019, and it progressed through mainland China during January. The World Health Organization declared COVID-19 a public health emergency of international concern in late January. You'll be aware that there is increasing involvement of countries outside of mainland China, and this increases the likelihood that the WHO will eventually declare this a pandemic. As more countries become affected, the border measures that Australia has put in place for mainland China and Iran become increasingly less effective as more and more countries are impacted. And as more and more countries are impacted, it's increasingly likely that Australia will start to see an increased number of cases. As of 4 o'clock this afternoon, there are around 93,000 confirmed cases worldwide, 80,000 approximately in mainland China, and the remainder across multiple countries. Other countries with sustained community transmission include South Korea, Italy, and Iran. In Australia, as of today, there are 39 confirmed cases, and fortunately for us, no confirmed cases in the ACT. There's been one death to date in Western Australia. So I mentioned that we are starting to plan globally and nationally for a pandemic. So what do we know about pandemic impacts? Well, it really depends on the number of cases infected in a population and also varying population vulnerabilities, the transmissibility of the infection, and the spectrum of clinical severity. And they're all the things that we need to take into account when we're thinking about our health sector response to this outbreak. Now, the information on some of these parameters we mainly have from China that has still seen the vast majority of cases. And the latest advice is that this infection has a moderate transmissibility. So with a reproductive rate somewhere in the vicinity of 2 to 2.5, although we may see this go down as the infection takes hold across the world. There is a wide spectrum of disease, as we've tried to communicate to you, that ranges from respiratory illness that's quite mild, similar to a common cold, to pneumonia and death. Now, the proportion of truly asymptomatic infections is unclear, but it appears to be relatively rare and is not considered a major driver of transmission in this outbreak. So most of the disease is mild, as I've suggested, about 80%, 15% moderate, and these are people that probably need to be hospitalised, and 5% severe, so in the ICU category. With a case fatality rate between 1 and 4% in China, but this very much varied by location and the time during which that outbreak was unfolding in that country. We do know that severe illness, ICU admission and mortality is higher in the elderly and those with comorbid conditions. As you'd be aware, there's no vaccine yet available for this disease and no specific treatment measures. So the population health interventions that we're relying on is general hand hygiene and cough and respiratory etiquette, as well as case isolation and contact quarantine and social distancing measures. So that's sort of what we do know. What we don't know is what the transmissibility will look like in Australia, in our context, and what the clinical severity will look like with our high level of healthcare in this country. And really we're relying on ongoing surveillance as this outbreak takes hold in Australia, and other particular research studies, things like the First Few Hundred study, which will look in detail at the virology and the clinical symptoms of those that are first affected by this disease in Australia and their close household contacts. And that'll give us a much more better understanding of pre-symptomatic and asymptomatic transmission, of the incubation period and the period of infectiousness. We don't know the exact timing that community transmission is going to take hold in Australia or across this country, and how that will roll out. And as I said, we still don't really know the impact because the clinical severity is unknown. But there has been some national modelling done on varying scenarios. And the one where a lot of planning is sort of circulating around is based on a high severity and moderate transmissibility. So this is, I guess, a worst case scenario. So conservative in that we would be needing to prepare for high impact on our clinical services. But I don't think the widespread view is that this is a high severity outbreak. So I guess what I wanted to show here is it's a pictorial conceptual diagram, I guess, of the peak demand. And I haven't put any numbers against it because numbers are somewhat meaningless at this stage. But the vertical axis is the number of cases. And the horizontal axis is the weeks after which community transmission takes hold. And the four different colours are the different kind of, I guess, containment measures that we can put in place in Australia and the ACT. The red is unmitigated. If we do nothing, this is what the outbreak will look like. Blue is just self-quarantine, green is isolation of infected cases, and orange is the most, I guess, significant in terms of the measures, and it's quarantine and isolation. And basically what I want to demonstrate here is that with the orange, which is what we're working on at this stage, if we actually continue to quarantine contacts and isolate cases, then we're going to really slow the onset of the that increased rate in the number of cases, and we're going to really flatten the peak of the outbreak. And so this allows both for a lot of health sector preparation to undergo in that period before those cases really take off, but it also allows us to manage this peak burden more effectively across the health sector. So the key message, as I said, case isolation and contact quarantine reduces the peak burden but results in a longer epidemic. Overall, it will increase our healthcare use, but we'll see better outcomes. As anticipated, the ED triage pathway is going to be overwhelmed pretty early in this outbreak, and so we need to think about alternative models. And PPE use is very high in this scenario, but cohorting of cases can significantly reduce this. So we need to, I guess the learnings from this is that we need to continue with quarantining and isolation for as long as it's feasible to improve the ability of the health sector to manage demand. We need to plan for longer level of increased activity. We need to think about alternative models of care and using cohorting where possible. This is very text heavy, this slide, so apologies for that. But I just really wanted to reiterate the current summary of containment measures. So you'll be aware that since the 1st of February, foreign nationals from mainland China have not been able to enter until 14 days after leaving China. And then more recently, from the 1st of March, foreign nationals are not able to enter Australia until 14 days after leaving Iran because of the cases and the severity of cases in that country. Further containment measures are also in place for those permanent residents and citizens that are coming in from those countries. Those people are asked to quarantine themselves at home for 14 days after leaving those countries. Similar to previous advice, close contacts of a case must quarantine themselves for 14 days. And this is relatively new advice. Staff who have close contact in hospitals and or residential aged care facilities who are returning from other impacted and affected countries such as Italy and South Korea cannot attend work for 14 days after leaving these countries, but they do not need to be quarantined at home. And I'm happy to take questions on that. I won't spend too much on the case definitions. Suffice to say, there is now a link to a government website where you can see the ever-increasing number of countries that do pose a risk of COVID-19 transmission, and travel from those countries in the 14 days before illness onset or contact with a confirmed case is the EFI criteria for the suspect case definition, and the clinical criteria are fever or acute respiratory symptoms with or without fever. So turning briefly to PPE, we've based our PPE advice nationally in the ACT based on the recommendations of an Infection Prevention and Control Expert Advisory Group. It aligns with WHO advice. We recommend for routine care of suspected cases, contact and droplet precautions be used. For specimen collection from patients with mild or no respiratory symptoms, the same transmission-based precautions apply. For aerosol generating procedures and specimen collection from patients with severe symptoms suggestive of pneumonia, we recommend the addition of airborne precautions in a hospital setting. In terms of the evidence for the PPE recommendation, this is advice from the latest WHO review of the evidence for transmission routes. WHO is recommended that COVID-19 is transmitted via droplets and fomites during close unprotected contact, and I think droplets is the most significant mode of transmission. Airborne spread has not been reported, but is theoretically possible during aerosol generating procedures. Fecal virus shedding is something that we have seen in some of the cases in Australia and overseas. However, the fecal oral route does not appear to be a strong driver of COVID-19 transmission as well. Turning to cleaning advice. So this is advice for the reception areas and the consultation room. So after a patient leaves, do remember to take extra care to clean any surfaces that patients may have touched regularly. So think about door handles, chairs, the examination of the examination bed, desktops. We recommend a combined cleaning and disinfection procedure. So either a two-step procedure with a neutral detergent followed by a disinfectant, or a one-step procedure using a combined product. We recommend using a hospital-grade TGA-listed disinfectant that's active against norovirus or coronavirus, and manufacturer's instructions should spell this out, as well as instructions for dilution and contact times. You can use wipes or liquid and disposable cloth, and use disposable equipment if possible, and remember to think about cleaning, wiping down your stethoscopes, blood pressure cuffs, and other equipment that will have come into contact with the patient. So for patients with mild or no respiratory symptoms, you don't need to leave the room vacant where you may have collected a specimen from, or where the patient has been for a period of time after specimen collection. You just need to clean it. If you've collected specimens, then you do need to continue to be mindful of contact and droplet precautions when you're cleaning them. There is ACT Health fact sheets on our website for detailed guidance on both specimen collection and donning and doffing PPE. And as usual practice, disposal of all waste, including PPE, should be through your usual procedures and clinical waste. So some further updates that have been communicated to you this week. There's no longer a requirement for GPs to phone CDC and ACT Health to notify of every test for COVID-19. We understand that's a very onerous procedure, but we do ask if you could contact us for people being tested who have recently returned from mainland and China or Iran, because they're in quarantine and we will need to be in touch with them regardless of their test result. All patients who are tested for COVID-19, you will know should self-isolate at home while awaiting test results. And we are also asking GPs who ordered the test to follow up the result and notify the patient if the result is negative, as you would ordinarily, or CDC if it's positive. And CDC will implement contact tracing and other public health measures. ACT Pathology is now running a diagnostic test on site, so it has the fastest turnaround time at this point in time. It may be in the near future that commercial assays will be made available to private laboratories, and that will greatly increase our testing availability and choice for GPs. So if your practice is unable to collect specimens or GPs in the practice are not willing to collect specimens, we would preference referring the patient to ACT Pathology at Canberra Hospital, just because it gets us the quickest turnaround time, reduces the time that your patient is in isolation. Having said that, Capital Pathology have a list of centres that can collect specimens for these patients. There's an ACT Health fact sheet on those centres that can collect a specimen. But the turnaround time from Capital Pathology is significantly longer than ACT Health. Either call ahead, or it's quite fine to ask your patient to call ahead to notify the collection centre, and they'll be told of the procedure for entering the centre. And please give your patient a surgical mask to go to the centre. A little bit to finish the talk on ACT response and planning, because I'm sure this is of interest. So our Health Emergency Control Centre was activated on the 29th of January. The Chief Health Officer is the Health Controller, and I'm part of the HEC. We have an ACT-wide epidemic infectious disease annex. It's a plan, but it's basically an annex of the Health Emergency Plan, and that's been activated. The Health Sector Emergency Management Committee, it does have primary care representation on it, is the Operational Health Committee, and that has met several times. And there is an ACT Health Sector Planning Framework for COVID-19 that is sort of in the final stages of development. And it addresses what our existing plans are, what the objectives are, and our activities by the stages of the pandemic. So, some of these things we can talk about in more detail, but the progressive actions that are being planned for are increasing our home support for cases and contacts, and potentially for domiciliary or home testing. The ACT Primary Care Disaster Response Working Group has been stood up. This is a working group that was that came together during the bushfire and smoke crisis back in January 2020. It perhaps needs a different working title. Disaster is really hopefully not what we're facing, but maybe emergency response working group would be better. Respiratory assessment clinics are being planned for. We're looking at capacity across public and private hospitals, patient flow and models of care, ICU capacity and sector-wide response. It's still a little bit, apart from the elderly and those with comorbid conditions, it's still a little bit unclear what the other at-risk groups are, but we're certainly across the country planning for response among Aboriginal and Torres Strait Islander communities, particularly in remote communities, which really doesn't apply in the ACT in terms of remote Indigenous communities. And we've got a strong communication strategy. So this is where we go for more information. Hopefully you've been receiving Chief Health Officer alerts through the email, but they're also available online at this web address. The Australian Government has a lot of resources available to health providers as well as their patients, as does the ACT Health. And there is a video there on the safe use of PPE. So I'm just going to invite Anne-Marie up to the podium to say a few words on her experience in a general practice, and we'll go from there. Thank you.
Thank you, Vanessa. Thanks, Vanessa, very much for the opportunity to hear you tonight. I think it's really important that GPs have this opportunity to hear directly from the Public Health Unit. And thanks again to Capital Health Network for facilitating this. So my name's Anne-Marie Svoboda. I'm the Medical Director of GP Liaison at the Canberra Hospital, where I work part-time, and the rest of the time I'm a practicing GP at Fisher Family Practice, which is a medium-sized practice in Western Creek. So I've just been asked to give a little bit of a general practice perspective on things as a practicing GP, very much at the coalface of what's happening in general practice, and spoken to many GPs. So I just want to briefly talk about the experience that we're having at our practice and some procedures that we're currently putting in place and some of our forward planning, and hopefully that can assist all the GPs out there who will be also thinking about it, talking amongst their group and making plans. And before I actually say too much more, I really want to acknowledge that all GP practices are very different, and GPs will be thinking about this in the context of their own location, their own personal circumstances, perhaps even their own health issues. So what I say is about my experience, and our practice experience and your experience might be very different. And I really encourage all the GPs out there who are listening to please get your questions in now so that Vanessa can answer some of those questions for us. So in our practice at the moment, our current status is that we're mainly seeing worried well, as I'm sure everybody is doing. So seeing lots of patients who are anxious about COVID-19 and wanting general information and advice on what this means for them. So we're talking a lot about preventative measures, about hand hygiene, about social distancing, and about their own personal risk factors, and doing what we do every day in good general practice is looking after the care of our patients. Then there's a lot of people that we're seeing who are seeking some travel advice. So either they have planned trips overseas or they're thinking about whether or not they should be cancelling their trips, and or asking for support letters even to cancel trips. So referring people to the Smart Travel website and talking to them about what's happening overseas and directing them to appropriate information. So at our practice so far, we have seen 3 people who have met the case definition for testing, and we have conducted those tests. Fortunately, so far, we have no tests that are positive, which is good. And we're also looking at our procedures and meeting regularly to review how to manage this as it's evolving. So at the moment, we have 3 points of triage in our practice. We have our online booking system, which puts up a warning to patients who try to make a booking. This directs people with respiratory infections or who have a travel history to phone the practice to discuss making an arrangement for appointments. Then when people do ring the practice, we have a reception script so that our receptionists are asking every person who rings the practice to make an appointment questions about respiratory symptoms and their travel history. And again, when people walk into the practice and they come to the desk, they're again being asked about respiratory symptoms and travel history. And hopefully with those measures, we are anticipating who needs to be seen or whether or not they need to be redirected elsewhere. We also have signs in the surgery at the front door and at the reception desk, and we have respiratory masks, which we've actually now put behind the counter to stop people pilfering our masks. So what we are actually doing with people, if anybody has a respiratory symptom, we're asking them to put a mask on. For people who have a travel history and no symptoms, we are asking them to defer making an appointment, who have travel history to areas of concern, but no symptoms. We're asking them to defer an appointment for 14 days, but to then contact the practice again if they do develop respiratory symptoms. So all non-essential consultations can be done after that 14-day period. If they do have a travel history and mild symptoms, we are happy to see them in our practice, but we are allocating them appropriate times. So either we are asking them to come at the lunch hour when there'll be no patients in the waiting room, or at the end of a session, again, when there are no patients in the waiting room. They're asked to wait outside, they're asked to have a mask on, and once we are ready to see them, they can be directed immediately into a room room with a closed door, and the doctor is seeing them with PPE, and if necessary, then doing the testing. As I said, we've only had 3 people. Billing is done afterwards, so the patient's immediately directed out of the surgery so that there's no contact then with the reception staff or anybody in the waiting room. And our procedure is that if somebody has a travel history and they're unwell, that they will be directed to the emergency department for assessment and testing in the emergency department. So just moving forward, we've been thinking a lot about what to do in coming weeks as things do change, and it's obvious that things are changing rapidly with the notifications that we're getting and what we're also seeing on the media as well, and including social media. So the main concerns that have been coming up for us in the practice is low stock of PPE. And this is quite a worry for us. We've had difficulty getting surgical masks, and at the moment we have estimated that we have approximately 3 weeks of remaining of our supply of surgical masks, and that potentially can impact on us being able to see people. We've also had some trouble sourcing appropriate cleaning equipment and hand sanitizer, and again, these are issues for us with being able to continue to see people. And also we are thinking about business issues and the financial implications for the practices. I'm sure are issues that all GPs are thinking about. Our biggest risk, we think, is for unannounced patients. So they're the ones that we're really worried about, people who come in who have a travel history but haven't notified us. And even yesterday that happened in our practice. We had somebody who had returned from Japan 2 days ago, made an online booking, ignored all the information that we had, and came into the waiting room and into the doctor's room without a mask, which is very frustrating. But I think that that's where our risks really lie, is those patients who we haven't anticipated. We're also having regular meetings. We had a practice meeting, a doctor's meeting yesterday. Our reception staff are also having regular meetings to reinforce all these things and to ensure that we're communicating well within our practice and talking about the issues and trying to troubleshoot where we are seeing problems. We have internal email communication, and we have a resource folder with all the information in our practice software. So that's all I really wanted to talk about. I know that's perspective from our practice, but I think it's helpful for other GPs to know what's going on perhaps in other practices. I'm interested in what others are doing. I'd like to pass back on to Vanessa now, and I hope that everybody finds this very valuable and that you are bringing up your questions now.
Thanks so much, Anne-Marie. I found that really helpful, and it's really important for ACT Health to understand the challenges that providers are facing out there in the community. So we've got a lot of questions. I'm trying to flick through any that I can give to Anne-Marie and Sandy, but I'm not seeing a lot at this stage. So you've got me again. So we'll start with the questions around disease epidemiology, clinical features and testing. One of the questions refers to reports in the media of people who are demonstrating an incubation period of longer than 14 days. So as a consequence, shouldn't we be telling everyone who presents to a GP clinic with respiratory symptoms from one of the countries with COVID-19 transmission to wear a surgical mask regardless of when they arrive in Australia? So yes, there have been isolated media reports of potential incubation periods that are longer than 14 days, but at this stage, there's really no conclusive evidence that these individuals, A, didn't have a secondary exposure during that time, or that there wasn't perhaps not a clear, I guess, case history of when exact onset of symptoms were. Because this disease can often start with very, very mild symptoms, I think people can easily overlook some of those milder symptoms. And I don't think we're convinced, at least in the communicable disease community, that probably didn't play a factor in some of those reports. What we're mainly seeing is the mean incubation period around 5 to 7 days. So it's actually much more likely that the most common incubation period is actually shorter rather than longer than the outer range of 14 days. Because we have to put some parameters around our PP use, and how we actually run our hospitals and health services. We just need to rely on the best evidence that the WHO and the international research community can give us around that. So at this stage, we're saying the outer range is 14 days, but the mean is probably around 5. So there's no other public health body that are advising for a longer than 14-day period of self-isolation or for testing for people outside of that range. So the rate of asymptomatic infection is also unclear, and I did make that point. And certainly when we gave this first webinar, there had just been a journal article published on potential transmission from a pre-symptomatic case from a person that had arrived from mainland China to attend a business meeting in Germany, and then other cases were seeded from that index case. Actually, I think subsequent correspondence in relation to that article did suggest that not all the facts were correct, and we're far less certain at this point that there is actually any asymptomatic transmission. Certainly, we don't think it's a major driver like it can be in flu. However, I guess because we're actually putting all of this effort into quarantine of well contacts, we're still taking a very precautionary approach on that. So the proportion of truly asymptomatic infections is really, appears to be really rare, and we don't think it's a driver infection. So again, telling everyone to enter your practice who's travelled from an affected country, regardless of whether they have symptoms, isn't the best use of the scarce resource that we have in the PPE. The period of viral shedding is also unclear. What about the scenario where someone has arrived from China, develops symptoms on day 12 and decides to seek medical attention on day 16? So if they develop symptoms on day 12, then they need testing because that's within 14 days of leaving China. It would just, if they're positive, it would be a bigger contact tracing nightmare because there may be 4 days where they've been going around town and have been unknowingly infecting other people. A question about the mortality of different age groups. You know, this information is still evolving, and like I said in the presentation, most of our clinical data comes from the cases in China. There was recently a WHO published report of over 72,000 cases in China. So the overall mortality rate, case fatality rate, was reported to be 2.6%. It's likely that there was still major under-ascertainment of cases, so I would suggest it's lower than that. Outside of Hubei province, the mortality rate was estimated at 0.4%. So the location is really critical. In terms of different mortality rates across different population demographics, I've already indicated that people over 70, people with comorbid conditions, are at a much higher risk of severe disease and death. And so, you know, 4% may be more applicable to that age group, but or higher. But I think we still just don't have the data to say for sure. The next question is about whether immunocompromised people are at higher risk. Again, we don't know, that it would make intuitive biological sense that if you have a reduced immune system, then you are more at risk of severe disease. And that's generally what we know about other respiratory viruses, but we don't know. And based on the data, it's unclear, so that's only a hypothetical. Question about whether patients can pay for a private test outside of the case definition. I guess there's two things to say there. Testing capability, I guess, is finite across the jurisdictions. We're well within capability at this time, so that's okay. But I discourage you from testing someone you didn't really think fitted, not the case definition, because you can use your clinical judgment outside of that case definition, but who you really didn't think had COVID-19. Because I don't think it's great for the system, and it's not necessarily good for that patient's anxiety either. But if you feel you want to test someone outside of the case definition, then that's absolutely fine to use your clinical judgment at this point in the epidemic. And we trust that you will do that, and sometimes public health will make a decision outside of the case definition as well, based on our judgment. The question around why we need a nasopharyngeal swab and a throat swab plus or minus sputum. So I guess at this stage, the more tests, the more sample, the better. We know from MERS in particular that lower respiratory samples had a higher yield of detection than upper respiratory samples. So that's why we say if someone has lower respiratory symptoms, they can produce a sputum sample to collect it. We asked for 2 upper respiratory samples because we're still, you know, the test is, it's not an accredited test. So we still need some time to work out the sensitivity and specificity of this test. And we want to make sure that when we're saying someone is negative, that we can be as certain as possible that they're negative. So often we need more samples to do that. In some labs, 1 sample will be used for the respiratory panel and another sample for the SARS-CoV-2 assay. So that's the reason that is the gold standard at this point in the epidemic. That may be reassessed as we move through it. How do we assess that a patient has recovered? So there are details, criteria around this in the national CDNA public health guideline. Ostensibly, you have to have complete resolution of symptoms, you have to have had no fever for 48 hours, and 2 negative PCR tests greater than 24 hours apart. That is the criteria for saying that someone can come out of isolation. We believe, we don't know for how long a person is actually infectious. We have had some people, some confirmed cases who are fully recovered but have ongoing PCR positive tests. We don't yet know what that means. So ostensibly you have to be resolved of your symptoms in the first place and then have negative tests before we're happy to release someone from isolation. How long does the virus remain on surfaces? Sandy, is that something you want to answer? I'm getting tired up here.
I'm not sure. There seems to be, they haven't done a lot of studies because of because it's all so new, but I think they're generally saying 72 hours, perhaps longer. I mean, it depends on the amount of soiling with it, of course, because viruses do need to be inside cells to survive. So it just depends on the amount of soiling that's with them. So, I mean, I can't give you a definite answer.
And what about once they're clean? Once you've cleaned the surface?
No problem.
Well, hopefully once you've cleaned it, you've removed it all. By cleaning with your detergents, you're removing most of the bioburden, and then any disinfectants in it should hopefully clean anything that's left behind. Do you want me to do my infection control questions while I'm here?
Do you have some? Yeah, go for it.
I have a couple.
Great.
A couple of questions. One of the questions asked was, is there a list of recommended cleaning products? And I haven't actually, I don't have a list. There are a lot of products out there. It isn't a hard virus to kill. It's an envelope virus. So that a lot of disinfectants, and there's different types of different disinfectants that work by different means. So it is quite an easy virus to kill. If you ring your medical supplier, they should be able to tell you what products they've got available at the moment that they can use for coronavirus. Most of the labels, as Vanessa mentioned before, should state that they're effective against, if they're effective against norovirus, they should be effective against coronavirus. So if they say the coronavirus or the norovirus, that they're certainly ones that you can use. Yeah, so I can't really give you lots of products that you can use. It would be a matter of contacting your supplier to see what they've got. But of course, we are quite open for you to give us a call at Health Protection Service if you've got one in mind that you want to use or that they suggest, and we'll let you know if we think it would be suitable. The only other infection control question that I've been asked about is how do you go about cleaning cloth seats? This is quite a good question, and I guess it would depend on, I mean, cloth seats, it's like carpet on the floor in a healthcare area. It's better if it's a vinyl floor, but if you do have a cloth seat, it would be harder to clean. Generally, it's more likely to be the handles of the arms of the chair and the sides of a chair where, you know, they're pulling their seat forward that they might be touching, and generally they're not covered in cloth. So concentrate on those areas. It would be like sitting on a bus or a chair anywhere else. I don't know how much transmission you'd get from a cloth seat. If you know it is quite heavily soiled, then you should remove it from the waiting room or the treatment room. If you have an area in your waiting, I'm just thinking off the top of my head here, if you have an area in your waiting room where you're social distancing that patient, then it might be a good idea to provide a couple of either plastic or vinyl chairs that they can sit in over in that area that can be easily cleaned. And in your treatment room, if you know the patient is coming in and they've got respiratory, it could possibly be that you put a bluey over their seat or something like that to help keep the chair clean. Any chairs that do get heavily soiled would require to be cleaned with a detergent solution and a disinfectant, and possibly steam cleaned afterwards. Yeah, and I guess it's just a general reminder to remind all patients to clean their hands. You never know what you've been touching, and it's your hands that need to be kept clean to prevent transmission in those situations.
Thanks a lot. And I would say the same as Sandy in terms of we really don't know how long the virus remains on surfaces. The WHO advice is that the major route of transmission is via respiratory droplets, but that it may be transmitted via fomites. But we, as Sandy said, we're just not sure yet. So cleaning is the best preventive measure we can take there. Okay, I want to get to some PPE questions because I know that that's a concern. Although I don't think I have questions on PPE. Patients requesting clearance certificate is an issue. Yes, it is. We hear you on that. It's not, we haven't made it a requirement on employers that people that have been in quarantine or isolation need clearance certificates, or certainly in quarantine anyway. So if you're asymptomatic but you're in isolation because you've returned from a high risk area. We are aware though that some employers are asking their employees to reduce those. There's not a lot we or you can do about that. And I guess in health, we can't provide those clearance certificates because we're not seeing the patients clinically. So I guess I just wanted to reiterate that that's not a requirement from ACT Health Directorate, but you still may keep getting those requests, and I think you just need to use your best judgment on that. Can we do anything to confirm if people have really been out of China for 14 days before arriving back in Australia? So this must be a question related to the fact that a lot of people from mainland China who want to come to Australia are doing their 14 days of quarantine in a third country. They're really, I don't think there is too much we can do about that except take them at their word. But we do see that this increasingly is an issue, and it will probably be an issue for Iran as well. What happens if a staff or a doctor is exposed to a confirmed case? Do staff need to be tested, isolated, or not work for 14 days? So if staff have close contact, so close contact is 15 minutes face-to-face, or 2 hours in an enclosed space, and they haven't worn appropriate PPE, then they would fall into the category of being a contact and may be asked to quarantine for 14 days. If they've been wearing appropriate PPE and they don't fit those categories that I've just outlined, then they don't need to do anything at all, anything different, just go about the usual business. Info on gastrointestinal symptoms. So yes, some cases are reporting GI symptoms, diarrhea, nausea, gastrointestinal pain. It doesn't look to be as high as in what it is in MERS, although I guess as the epidemic evolves, we'll have more information on that. The PPE requirements are the same. In the national guidance document, we would recommend those people not to be preparing food, obviously, and not to work in a food handling business. But there's nothing different to do in terms of PPE. Do household contacts of people returning from China need to self-isolate as well? Only if they have travelled from China themselves. So if there is an adult in the family that's returned from a business trip, for example, and they go into a family with another partner and kids, they don't need to be quarantined unless that individual gets sick, and then they'll need to be in quarantine for so long as it takes to get a COVID-19 result on that case who's returned from China. A bit about planning. PPE supply, there it is. Will CDC be providing us with additional equipment as we use them? So ACT Health, Capital Health Network was provided with surgical masks from the National Medical Stockpile, as were public health networks, other primary healthcare networks, across the country. This was an interim measure while clinics tried to access their private supply through their usual mechanisms. ACT Health also purchased some stock of gowns and goggles, because we understood from GPs in the ACT that they didn't have those in stock at the time. So that has been distributed across practices in the ACT. And we understand, as Anne-Marie has said, and from a lot of other GPs, and we know ourselves, that there is PPE shortage supply throughout the country and internationally. So ACT Health has been trying to secure supply. As part of our health sector preparations, we're having as much problems as you are. What I would ask, and I guess the whole policy issue around PPE supply and securing up supply chain is being managed by the Commonwealth, so by the National Medical Stockpile branch, and they're working furiously to do that. What I would ask is, if you're really struggling with PPE, can you please contact the Capital Health Network in the first instance, so that they can collate a picture of what's needed, and then we will work with ACT Health around that. They will work with us in ACT Health. We understand this is a critical issue for you, and we are not going to change our recommendations around PPE because of current deflations in the supply chain. So we nationally and at a jurisdictional level, we're working very hard on this. Can we push for MBS telehealth consult rebates? I think this is an issue that's been raised by health ministers in the COAG Health Council. It's something that's been reported in the Australian Doctor Bulletin. I think it's a live issue. It's nothing that ACT Health can do anything about because it's a national issue, but I think that is really being actively looked at. Just looking at our time, we've got about 10 minutes left. Do we need to test people from a cruise ship who have not travelled to high-risk areas? It's a good question. I think a lot of cruises are being cancelled as we speak. I think we have to have quite a high index of suspicion from people on cruise ships. It's a breeding ground for infection. We know that from gastro and influenza outbreaks, and cruise ships usually have people on board from a wide variety of countries. So I'd probably have a low threshold to test in that scenario, even if your patient said, oh, there was, you know, it was only people from New Zealand on it, if they had the clinical symptoms and if it's within 14 days of leaving that cruise ship. I think I've answered that. Is there a plan for flu clinics? Has been given to me from the side. They want to ask their own questions, that's fair enough. Yes, so by flu clinics, I'm wondering if we're talking about COVID assessment and testing clinics. Yes. So yes, there are. We are looking at that. Firstly, you may or may not be aware that walk-in centres have started being available to see and test patients. I think Western went online yesterday and the others are sequentially going online from tomorrow. There'll be, if you follow Canberra Health Services Facebook or ACT Health Facebook, you'll see that information come out. So that's a great step in the right direction in terms of boosting the primary healthcare workforce to test. They are, however, at this point in time, seeing those patients alongside their other business as usual patients. We are definitely planning for standalone clinics. We just have to get to a tipping point really for those to activate those clinics because they're highly resource intensive. And that comes basically once our numbers of tests start to go up. As I said, we're still well within testing capacity, but it's in the pipeline. And it's something, it is part of the, I guess, models of care that has been investigated to relieve the burden on GPs ultimately when the cases increase and to bypass the bottleneck that is going to happen in EDs as well. Can we use fabric gowns and wash them? Was that you too, Anne-Marie?
I don't know about the mask bit. Fabric gowns, yes, fabric gowns can be worn. They're not going to offer you any protection from fluids because fabric isn't impermeable. But yes, they can be washed. You just have to wash them in a sanitised load. If your Capital Medical Supply, not Capital Medical Supplies, the linen services should be able to provide that for you, or you can do it yourself. It's just a matter of doing your washing in a hot wash, 65 degrees or higher. If you can't get your water that hot, you can add a laundry sanitizer. A lot of them are around in the supermarkets. Just follow the instructions on the label. There's quite a few of them around, but certainly, yes, if you wash them in a sanitised load, just described, you certainly can use the cloth gowns. And I guess if you wore cloth gowns and you were doing something where you think you're going to be sprayed with body fluids, then you could put a plastic apron around over the top of that if you needed to. But in general practice, I don't know if that's likely to happen, but yeah, certainly you can use cloth gowns. Masks, I'm not sure. We're not at that point yet, but we certainly don't like to reuse masks. Whether or not if we haven't got any at all, whether we end up having to make our own, I mean, that's a long way down the track, and that's something that we would need to deal with when that comes up.
Okay, thank you. At this stage, we are not planning on making our own. And I wouldn't at all recommend at this stage cloth masks as well. Please let us know if you get to that stage. We'll work something out. I've also been asked to reassure you that WIC's walk-in centres will be using ACT pathology for their testing as well. I actually think I'm getting near to the end of the questions. There was a question around community transmission, actually. So what's happened in New South Wales with the doctor who in recent days has been confirmed positive with COVID-19, and the source of exposure is not known for this individual. So that's our first example in Australia of localised community transmission. But I guess what I would reiterate is that is exceptionally localized at this point in time. So we're not yet at a stage where we would recommend, we'd recommend testing for any return traveller, let alone testing for people who haven't travelled, you know, willy-nilly. This individual, I guess, had, you know, a lot of patient contact, was initially not thought to have COVID-19, but on subsequent testing was positive. But I think for the average person walking in off the street who hasn't travelled or travelled to New Zealand and has respiratory symptoms that are, you know, unfortunately this disease is very non-specific, which doesn't help you at all. But, you know, common colds are common. We're coming into flu season. All of this is going to complicate the picture, so the epidemiology is really important. So at this stage, really focus on the suspect case definition. If you want to go outside of that, please do so on a case-by-case basis, but not on a holus bolus basis, if that makes sense.
Will flu
Flu
vaccinations be available earlier?
vaccinations will be available hopefully on time, which is progress. Because often we're told by the Commonwealth that it will be here at a certain time and it's often delayed. And I think the best I can say is it won't be delayed. We are planning to start deliveries around the 6th of April. And we are really ramping up to get those out quickly. We've done a lot of work in ACT Health to see what different clinics have used in the first month of vaccinating, and subject to capacity in your fridge, you'll have it all without having to do reordering, you know, in that really peak period of April through to the middle of May. So we're going to try and do everything we can do to assist there. They won't be any earlier than April. Okay, I think you must be getting sick of my voice by now. There are a few questions here that I need to take on notice to give you the, you know, the best available answer. I could give you a half answer, but I'd like to actually go away and think a little bit more about them, or look at a few resources to make sure I give you the most precise answer. They will be reflected in the updated version of our frequently asked questions that will come out later this week. And of course, this presentation will be available on the Capital Health Network website. You'll get an email about that. And I believe we're asking you to do an evaluation now. Yes, we are. Oh, excuse me, not very good extra control. So I want to thank you very much for attending. We really value your time. Excuse me, I don't have COVID-19. I have not travelled. And yeah, we look forward to providing you with more information as the weeks and months roll on. Thanks very much.